of FMGE in subject of biochemistry. I am Dr. Poonam Agrawal and I will be discussing various questions which was asked in subject biochemistry. The very first question was this, where 8-year-old child is presenting to pediatric OPD with bowing of legs, pigeon chest and widened wrist or cupping or fraying of the wrist seen on X-ray. On examination, there is also Harrison sulcus which is noted on the rib cage. Now, which of the vitamin deficiency is responsible for this? So, this is a very cute question and this is rickets case. A typical presentation is shown here and we all know that rickets is due to vitamin D deficiency. And in this picture you can see fraying of the wrist joint, fraying of the wrist here. Fraying means widening. And I have come with these pictures which is telling you about the pigeon chest deformity. You can also see rachitic rosary over here, the protuberances and Harrison sulcus. What is Harrison sulcus? It is along the 6th rib, there is a retraction of the muscle. So, these are very typical presentation of rickets and in addition to that there is a bowing of leg also. Now, in this also you can appreciate the ricket rosary and the Harrison sulcus. In the radiographic picture, Harrison sulcus will be all the more clear. Coming to the next question, the enzyme deficiency responsible for essential pentosuria. So, this is a very repeated and important question and there are few sets of MCQs which are asked very often around this topic. So, the pathway affected in essential pentosuria, you must know it is uronic acid pathway. I will come to the answer later. Let me tell you all possible MCQs around this topic. So, essential pentosuria, the pathway affected is uronic acid pathway. The enzyme which is deficient is L-xylulose reductase and the pentose which is coming out in the urine is the L-xylulose, right. So, these are the questions. It is a benign condition, uronic acid pathway is affected, enzyme deficient is L-xylulose reductase and the pentose which is going to come out in the urine is the L-xylulose, not the D-xylulose. So, in this question they asked what is the enzyme deficiency in essential pentosuria. This is also called benign pentosuria, mind it, benign pentosuria, it is absolutely a benign condition, right. So, the enzyme deficient is going to be L-xylulose reductase. So, in this recall there is no L-xylulose or D-xylulose. So, of course, we are going to mark xylulose reductase, but there will be question framed where they will be giving one option as L-xylulose reductase, another option as D-xylulose reductase. So, there you have to pay attention that it is going to be L-xylulose reductase which is deficient and that is going to result in excretion of L-xylulose, not the D-xylulose in the urine. This will be more clearer to you once you see the uronic acid pathway, where you can see this is the uronic acid pathway, right. You can see glucose converted to UDP glucose, UDP glucuronic acid, D-glucuronic acid which is converted to L-xylulose, xylitol, D-xylulose, xylulose 5-phosphate and that enters the HMP shunt pathway after phosphorylation. So, this is the outline of uronic acid pathway. You do not need to remember uronic acid pathway step by step. Only the MCQ aspects you can remember and there you have to pay attention to this aspect, the xylitol. Before xylitol, can you appreciate xylitol here? Before xylitol, you have L-xylulose and after xylitol you have D-xylulose, right. So, this portion is very important for your MCQ. Now, when we talk about the conversion of L-xylulose to xylitol, we have got a requirement of enzyme which is xylulose reductase. So, if that is going to be deficient, what will happen? This step will not be taking place and L-xylulose will come out in the urine and this is called benign pentosuria or essential pentosuria which is very often asked to you. And examiners are asking this, but please understand it is an absolute benign condition and patient is not having any sorts of problem. That is why this is called essential or benign pentosuria. And it is accidentally being detected by positive Benedict test in the urine. You know Benedict test is for reducing sugar in the urine and L-xylulose is one of the reducing sugar. So, accidentally when Benedict test is coming positive in a patient who is not a diabetic patient, then certainly the diagnosis of essential pentosuria should be kept in mind, right. So, this was regarding this question, essential pentosuria. Now, I will be taking the next question. So, if you have any doubt, you can ask. Now, which enzyme is responsible for removal of triacylglycerol from the chylomicron? Now, this is a very interesting question, and answer for this question is going to be lipoprotein lipase enzyme. So, whenever we are talking about chylomicron, or in that matter the VLDL, these chylomicron and VLDL, they have got lot of triacylglycerol in their core section, and during circulation what is happening, they are encountering capillary endothelium, and at the wall of the capillary endothelium you have a enzyme called lipoprotein lipase enzyme, the same enzyme in question, and this endothelial lipoprotein lipase enzyme is acting on the triacylglycerol of chylomicron as well as the triacylglycerol of VLDL, and is going to do the lipolysis. Means this lipoprotein lipase is going to break the triacylglycerol and will remove its fatty acid, which will go to the tissue, right. So, the fatty acid is going to go to the tissue, and from VLDL also the fatty acid is going to go to the tissue. So, the enzyme which is responsible for removal of fatty acid from the triacylglycerol of the core of chylomicron and the VLDL is going to be lipoprotein lipase. So, answer in this question is going to be option A. Coming to the next question. A 6-year-old boy is worked up for the glycosamine storage disorder. Glycosamine is nothing but it is mucopolysaccharide, right. So, mucopolysaccharidosis they are talking about. Now, where the diagnosis was done for Natovich syndrome. This is a very rare syndrome, it is type 9 mucopolysaccharide storage disorder, type 9 mucopolysaccharidosis. Now, what is the enzyme deficiency in this condition? So, please understand the enzyme which is deficient is hyaluronidase. In this mucopolysaccharidosis, which is one of the rare one in occurrence as well as rare in the exam, I was like happily surprised to see this syndrome, and this is type 9 mucopolysaccharidosis which is due to deficiency of hyaluronidase enzyme. So, hyaluronic acid is not degraded. So, what is deposited in this? It is hyaluronic acid which is deposited in this disorder, right. So, if you have any doubt you can ask, otherwise I will go ahead with the next question. Now, one Mr. X, who is chronic alcoholic middle aged elderly male, was rushed to the clinic by wife, accompanied by wife with gum bleeding, petechial hemorrhages, corkscrew hair pattern, generalized weakness, lethargy. The patient also has neurological symptoms and abnormalities since long time. He is having poor wound healing. So, it looks like multiple trace elements are deficient in this person because he is a chronic alcoholic. So, there will be severe malnutrition. What is the most likely vitamin deficiency? They are specifically asking the vitamin deficiency. So, the catch here is the gum bleeding and petechial hemorrhages. So, what vitamin deficiency you will be thinking of? It will be vitamin C deficiency. So, now you need to understand what is the role of vitamin C and why in vitamin C deficiency there is breakdown of capillaries resulting in petechial hemorrhages and the gum bleeding. So, for that you need to understand that vitamin C is very, very important for collagen synthesis, which is there in the blood vessel wall as well as in the bones. So, this collagen is a protein, right, and what is happening, you have one very important enzyme called hydroxylase. In fact, you need to prolyl hydroxylase and lysyl hydroxylase enzyme for post-translational modification of this collagen polypeptide, where proline and lysine are converted to hydroxyproline and hydroxylysine. There is one more question of similar type, I will be showing you further. So, the vitamin C is needed for prolyl and lysyl hydroxylase activity. So, if there is vitamin C deficiency, these enzymes will not act and the collagen polypeptide will not be formed, and that will result in fragility of blood vessels, and that will cause the gum bleeding and petechial hemorrhages. Petechial hemorrhages are small bleeding patches in the skin which can be visible. So, the question is simple, though it is elaborative one. but the stem they have unnecessarily elaborated so much. The catch in the question was completing in the petechial hemorrhages, and the answer was vitamin C. See, this is the similar question which is recalled, that which of the following enzyme deficiency will affect the collagen maturation process during collagen synthesis in vitamin C deficiency. So, now you know the answer by this time, it is prolyl hydroxylase, and lysyl hydroxylase is also the enzyme which is affected by lack of vitamin C. So, this is the picture which is showing how the proline and lysine are independently converted to hydroxyproline, hydroxylysine in vitamin C dependent manner by action of prolyl and lysyl hydroxylase enzyme, and the ferrous is converted to ferric in this process. This picture is talking about the collagen post translational modification. You can see this is endoplasmic reticulum lumen, and this is messenger RNA which is producing a pre-pro collagen, and this pre-pro collagen is undergoing post translational modification at multiple steps to finally form you the collagen. So, during this process only you have the action of prolyl hydroxylase activity as well as the lysyl hydroxylase activity, and ultimately the mature collagen is formed, which is excreted out of the cell. Collagen is a extracellular protein, remember that, extracellular protein, it is not intracellular, extracellular protein. That is why it is produced on rough endoplasmic reticulum, not on smooth endoplasmic reticulum, because all extracellular protein which are going to come out of the cell are produced on the rough endoplasmic reticulum, that is the rough ribosomes which are studied on the endoplasmic reticulum, and those proteins which are going to stay within the cell, that intracellular proteins, they are produced by smooth endoplasmic reticulum, smooth ribosomes which are lying free in the cytosol, free ribosomes. So, you have two types of ribosome, free and bound. So, bound ribosomes are responsible for making of protein which are meant for excretion out of the cell. So, collagen is actually produced on the bound ribosome. That also is very frequently asked to you, bound ribosome. So, that you must know. Coming to the next question. Now, this baby is presenting with clinical feature which is shown in the image, including perioral and perianal rashes. You can see perioral, cheeks also are having rashes, perioral rashes also can be seen. Around the anus also you can see the rashes, and you can see the characteristic finding in this rash is that these rashes are very much symmetrical in nature, right, with the history of diarrhea is also there in this baby. So, which of the following is the most likely deficiency responsible for this condition? It is a very easy and repeated question, the zinc deficiency. Zinc deficiency results in this kind of presentation, it is a severe deficiency of zinc, and this condition is called acrodermatitis enteropathica. I write it here, acrodermatitis enteropathica. Remember, this is going to be frequently asked to you, and acrodermatitis means you have symmetrical butterfly rashes on the cheek. Enteropathica means there is a diarrhea, right. So, this is a classical presentation of severe zinc deficiency, which is otherwise very rare, but very common in your exams. Now, this slide is showing you all the problems which a person may encounter due to zinc deficiency, the hair loss, the skin lesion which I was talking to you, diarrhea, spots on the fingernails, white spots will be seen, loss of taste. This is again a very important, ageusia, that is the person is not able to taste any food. So, loss of taste or smell and sleep disturbance, reduced fertility, they all are seen in zinc deficiency. Always please remember these microminerals, macrominerals, vitamins, they are very important segment for your exam. So, do these topics thoroughly. Now, coming to the next question, a 40-year-old male is coming with black deposit in the vertebra which is visible on X-ray. Spine is also and over the knee joint also, sclera also is all showing the black pigmentation which is called ochronosis. Now, which enzyme deficiency is causing this condition? Again, this is a very repeated question. You must know it is a black pigment which is getting deposited in the intervertebral disc. Memorize these sites, the intervertebral disc, the skin, right, then synovial fluid, right, and even the conjunctiva, ear pinna. These are the preferable places where the black pigments can be seen, and this is seen in alkaptonuria. The disease name is alkaptonuria, which is due to defect in tyrosine catabolism, tyrosine amino acid catabolism, and that defect is the lack of one enzyme which is known as homogentisic acid oxidase enzyme. So, whenever you learn the tyrosine catabolism, you encounter number of enzymes, and please remember tyrosine catabolism is very important because lot of diseases are associated with defect of one or other enzyme. So, in tyrosine catabolism there is one enzyme which is called homogentisic acid oxidase, and that deficiency results in homogentisic acid getting deposited in various tissues, and when it gets deposited it is called ochronosis. So, alkaptonuria is when the homogentisic acid is excreted in the urine, alkaptonuria, which is characterized by black urine, right. So, black urine. But the same thing when it is like getting deposited in loose tissues, it is called ochronosis. So, they are not different diseases, alkaptonuria and ochronosis, they are a spectrum of same disease. And in alkaptonuria, the homogentisic acid is excreted in the urine, and in ochronosis it is deposited in the tissues. So, this is a tyrosine catabolism defect where the homogentisic acid oxidase enzyme is deficient. Now, please understand, I show you the next slide. You can see this is a normal urine, and you can see the urine turning black. Automatically the urine, without adding anything, if you leave the patient's urine on the table exposed to the atmospheric oxygen, after 4 hours that urine will automatically turn black, and that is a very typical presentation of alkaptonuria, and this is due to conversion of homogentisic acid into benzoquinone acetate, which gives a black discoloration. So, on exposure to oxidative stress or in presence of atmospheric oxygen, the homogentisic acid is converted to benzoquinone acetate, which is going to give black discoloration to the urine. And as I told you, even in the conjunctiva you can see the black deposit, ear pinna, right, and so these are, and even the palms can show the black deposit. Patient will complain of arthritis because of synovial fluid deposit. So, this is a condition of alkaptonuria, and please understand urine is having characteristic black color, but fresh urine is colorless. It is only after exposure to atmospheric oxygen the urine is turning black, and that urine is odorless. Please remember, it is odorless, there is no odor. Now, next question is, which of the following compound is getting deposited in the lens in diabetic cataract? Very simple question. Diabetic patient, you know, diabetic cataract is one of the complication of long standing diabetes, and the what compound is deposited? It is going to be sorbitol. In diabetic patient, as you understand, you have excessive glucose in the blood, and that floating glucose enters various tissues. Lens is one of them, and when it enters the lens, there is one enzyme which is waiting for this glucose, and that enzyme is called aldose reductase. Aldose reductase. So, in the lens, this aldose reductase is going to reduce this aldose, that is glucose, to sorbitol, and that will be seen only when excessive glucose is there in the blood and it is going to enter the lens, right. Okay. So, the sorbitol, yes Rahul, okay Rahul. So, now this sorbitol is a hygroscopic alcohol, it is there in the lens, it is going to absorb lot of water, and because of this what has happened, the lens is going to swell and its cell is going to burst, and that will initiate the cataract formation. So, this is a diabetic cataract which is due to sorbitol deposition, and the nature of the cataract is, what type of cataract you find in diabetic patient? The nature of the cataract in diabetic patient is the snowflake cataract. I show you the picture. Can you appreciate the snowflake presentation? Like it is like a snowstorm, snowflakes. Snowflake cataract is characteristic of diabetic cataract. One more cataract is very often asked to you, and that is oil drop cataract. I have got that picture as well, I will show you. Okay, can you appreciate this oil drop cataract, where it looks like a oil drop is there in the water. So, it is a oil drop cataract. This is characteristically seen in galactosemia. Both benign and classical galactosemia, baby will have bilateral cataract. And this is due to deposition of galactitol. This is due to deposition of galactitol. Why? Because galactose in galactosemia is converted to galactitol by same aldose reductase enzyme. Same aldose. Galactose is also aldose, no? So, the same aldose reductase enzyme which is sitting in the lens is converting the excessive galactose which is floating in the plasma and then entering the lens in galactosemia to galactitol, and this galactitol is giving you oil drop cataract. So, always very frequently asked in all sorts of exam, whether it is your next exam which is going to come, or it is going to be NEET or INI-CET. These cataract questions and biochemical connection is going to be very often repeated to you. So, remember snowflake cataract, diabetes, it is because of sorbitol deposition there, and oil drop cataract is seen in galactosemia, and that is due to galactitol deposition there, right. And the culprit enzyme is same in both the problems, diabetic cataract and galactosemic cataract, and that culprit enzyme is aldose reductase. All right. Any doubt in this? All right, very good. Now, coming to next question. Next question is 8-year-old boy coming to pediatric OPD with father having frequent fracture in the right lower limb. Frequent fracture is seen in the right lower limb. Father is also adding that this is third time the son is sustaining fracture, but the orthopedician is telling no external cast is required, and patient is prescribed some painkiller for occasional pain on the right thigh region. On examination, boy was found to have bluish discoloration of sclera. This is a catch. And a barrel shaped chest and triangular face. What is the most likely diagnosis? It is a osteogenesis imperfecta, or otherwise called brittle bone disease. This is due to collagen malformation, and there is a mutation in the one of the gene of the collagen. So, it is a brittle bone disease, osteogenesis imperfecta. If I show you the picture, you can see these are the main areas which are getting affected in osteogenesis imperfecta: frequent fracture, joint hypermotility, mobility, then dentition imperfection, blue sclera is very characteristic finding. And you can see this picture where X-ray is shown of a child of suffering with osteogenesis imperfecta. You can see disfiguring of bones here in the lower limb. This is due to repeated fracture and auto healing. The baby is going to show the bony deformities, and this is osteogenesis imperfecta. And the gene which is affected is, you remember this gene as well, sometime they may ask you this also. In osteogenesis imperfecta, COL1A1 and COL1A2 genes are getting affected. All right, very good. So, this is about osteogenesis, and blue sclera is characteristic. And you can see this picture talking about blue sclera. Hearing loss is also there in osteogenesis imperfecta, dentition imperfection, and multiple fractures, right. Coming to the next question. Now, what test will be done in a patient before starting anti-malarial therapy who has a family history of hemolytic anemia? So, this is a case of G6PD deficiency. Whenever anti-malarial drug Primaquine they give you in the question, always this G6PD should come in your mind. G6PD is glucose 6-phosphate dehydrogenase enzyme, which is the rate limiting enzyme of HMP shunt pathway. If this enzyme is deficient, the person will be prone for hemolysis, and anti-malarial drug like Primaquine is going to increase the oxidative stress in the cell So, if the person is having G6PD deficiency, the hemolysis will be precipitated. So, the answer in this question is going to be G6PD analysis, because drug induced hemolysis is most often seen in those individuals who are having underlying deficiency of G6PD, glucose 6 phosphate dehydrogenase enzyme deficiency. And why so? Why there is a hemolysis? The answer is very simple. The answer says that HMP pathway is responsible for making of NADPH, and this NADPH protects the RBC against the oxidative stress. So, if this G6PD is deficient, HMP shunt pathway will not be producing NADPH and there will be hemolysis, right. So, this is a very easy straightforward question, but very much repeated one, you must know. Coming to the next question, acetyl-CoA in prolonged starvation is most likely used for. Now, I must say that acetyl-CoA is a magical molecule. If they are talking about the fate of acetyl-CoA in well-fed condition, it is going to be different. The fate of acetyl-CoA in the starvation, the fate of acetyl-CoA is going to be different. In this question, they are asking you in starvation, please remember, in starvation the acetyl-CoA will be diverted for making of ketone body. Ketone body. So, the answer is going to be this. So, this you must know, and as I was telling you, this acetyl-CoA is a magical molecule, and if I write it here only, this is acetyl-CoA. It is a very central molecule for in biochemistry. The sources are so many, and the usage of acetyl-CoA is so many. Now, let us discuss this in a while. So, when we are talking about the sources of acetyl-CoA, please understand the glucose oxidation in aerobic stage, it will give you acetyl-CoA, right. Fatty acid oxidation, it also will give you acetyl-CoA. The ketone body utilization is also going to give you acetyl-CoA. Now, when we are talking about the usage, the acetyl-CoA will be used for the synthesis of fatty acid, number 1. The acetyl-CoA will be used in the TCA cycle for ATP production, number 2, and that is a major fate of acetyl-CoA, most of the time you understand that. And the fate of acetyl-CoA you must know even is the ketone body synthesis. So, now when what is happening? What is the source of acetyl-CoA in what condition? What is the future of acetyl-CoA in what condition is all the whole of the biochemistry, right. So, when you are talking about starvation, the source of acetyl-CoA is the fatty acid beta oxidation, and the fate of acetyl-CoA is the TCA of course, but in addition even the ketone body synthesis, right. So, acetyl-CoA is a very important point which you must know. And in well-fed state, the acetyl-CoA comes from aerobic glucose oxidation and it goes for fatty acid synthesis in addition to TCA cycle. Coming to next question, now which of the following would cause a rightward shift of oxygen dissociation curve? 1000 times they have repeated this question. So, you must know the oxygen dissociation curve perfectly well. So, let us talk about the oxygen dissociation curve first, and then we will come to the the options there. Okay, very good, very good. In Sakib, you have done correct. Correctly you have answered this ketogenesis. Now, coming to the next question, the oxygen dissociation curve, as I have told you, it is a very important curve. Please remember, and this is the most simplified curve which I have got for you, and you can see this is oxygen saturation which is represented on y axis and partial pressure of oxygen on the x axis. You can see a sigmoidal curve. Now, rightward shift means this line is telling you the normal oxygen dissociation curve, right, and the rightward shift means will be like this, means there will be easy dissociation of oxygen, at one particular pressure of oxygen, you will have more of the desaturation, right. So, this is rightward shift, and that is seen in all increased thing, increased protons, that is acidosis, increased partial pressure carbon dioxide, increased 2,3 BPG, increased temperature, everything when increased it shifts to the right. Only one thing which is decreased, and that is going to be the pH, and of course, when hydrogen is increased sorry, the pH will be decreased. Right. And when we talk about left, everything will be decreased except pH, which will be increased. So, when we are talking about leftward shift, everything will be decreased. The partial pressure of carbon dioxide will be decreased, hydrogen will be decreased, that is it will be alkalosis, 2,3 bisphosphoglycerate also will be decreased, temperature will be decreased, hemoglobin F, it will be leftward shift. The only thing which is increased here is the pH, right. So, this is how you must remember this oxygen dissociation curve, and this is the simplest fashion in which you can remember this ODC, and rightward shift and leftward shift you must not confuse in the exam. Now, coming to this rightward shift, which of the following will cause? I said increased hydrogen, increased carbon dioxide, that is acidosis. I said HPF, leftward shift, right. Blood bank blood is also leftward shift because the storage of oxygen is there. Decreased temperature is also leftward shift. So, answer in this question is going to be acidosis. Any doubt? Rahul, Mohammed, Saqib? If no doubt, we go to the next question. And now, which of the following best describes the control of enzyme activity by phosphorylation and dephosphorylation? Now, this is a very beautiful but a straightforward question. Whenever we are talking about enzyme activity regulation, we have got multiple aspects by which the enzyme can be regulated. You can change the enzyme activity by changing its concentration. You can change the enzyme activity by bringing certain factors which will affect the existing enzyme, they are called allosteric factors. You can change the activity of enzyme by covalently modifying that enzyme, by adding the phosphate, by dissociating the phosphate, by adding the hydrogen, by dissociating the hydrogen. This kind of adding and dissociating by making or breaking a covalent bond is called covalent modification. I hope you understand that this, suppose this is the enzyme, enzymes are protein, a particular amino acid is binding with some XYZ factor, maybe a phosphate, maybe a ribose, maybe a sulfate. By making of a covalent bond, it is called the covalent modification. Similar fashion, if this covalent bond is broken and that particular XYZ group is like dissociated, it is again called covalent modification. So, covalent modification is a very important type of modification where a particular group, maybe a phosphate, maybe a ribose, maybe a histone, maybe acetyl, maybe a hydrogen, maybe a methyl, may get attached to the amino acid or may get dissociated from the amino acid either by making or breaking of the covalent bond, and this is called covalent modification. So, it is a very easy question. I hope that everybody must have attempted it correctly. So, answer is only covalent modification. Coming to the next question. Now, a patient who is coming with arthritis, arthroscopy is going to reveal the blackening of the joint, which enzyme deficiency. I think it is a replica of the same question, recall, and it is again the ochronosis or alkaptonuria where the deficiency of homogentic acid oxidase enzyme is seen. All right, very good. Archita Sharma, negative inhibition. ठीक है, it's all right Archita, negative inhibition also is not going to be the answer. It's a very straightforward question which is talking about the covalent modification, right? Very good. Now, coming to the next question. Which of the following enzyme is typically elevated in prostatic cancer? It's again a very straightforward question, the acid phosphatase enzyme, because acid phosphatase enzyme is richly found in the prostate cell. So, even in benign hyperplasia, benign prostatic hyperplasia, you will have high amount of acid phosphatase in the blood. And of course, in prostatic cancer, the prostate specific antigen is high, the acid phosphatase is high. So, the answer is going to be acid phosphatase in this question, right. So, Archita, any doubt till now? And if not, Rahul, we will proceed further. Mohammed Saqib, I hope that you are following the class. Now, coming to the next question, that during starvation, which of the following hormone is primarily responsible for maintaining the blood glucose level? It's a very easy question, and it goes by a trick. Whenever there is a glucose in the blood, which is there in the well-fed state, right. So, well-fed state in a normal healthy individual, glucose will come to the blood, it will fetch insulin from the beta cell pancreas to handle that glucose, to lower down that glucose. On the other hand, in fasting or starvation, when the blood glucose is low, that time it will stimulate alpha cell and glucagon will be secreted, glucagon, growth hormone, cortisol, norepinephrine, all these will be secreted, which will try to raise up the glucose in the blood. So, during starvation, which hormone is responsible for maintaining the blood glucose level? It is going to be glucagon, because it is going to break the glycogen to release its glucose to the blood. This glucagon will stimulate the process of gluconeogenesis and will raise the blood glucose level, right. So, the answer in this question is going to be glucagon. Okay. Archita, of course, like if glucagon is secreted, then insulin will not be secreted. See, it's all when you talk about the metabolism in biochemistry, the core crux is whenever in a normal healthy person blood glucose is high, normal healthy I am adding, normal healthy person blood glucose is high, that glucose need to be lowered down. For that insulin is coming and lowering the blood glucose by various mechanisms. And on the other hand, when there is fasting or starvation, when the person is not eating anything, blood glucose is low, that time the system will do something which will secrete glucagon so that the glucose level is going up, and by that is done by increasing the liver glycogenolysis and gluconeogenesis. All right. No, Archita, insulin decrease first will not be the answer. So, if one option was that also, that in first the insulin will be decreased, that will not be the correct option, and which is produced to maintain the blood glucose, answer will be glucagon, straightforward. It is like if you have little doubt in this, please remember we always talk about insulin glucagon ratio. We do not talk about the individual level of insulin or glucagon in the blood during metabolism alterations. It is only always Ig ratio. So, insulin may be normal, glucagon may be up. So, if we will say that glucagon is high, glucagon may be normal, insulin may be low, then we say insulin is low, right. So, that is how it is the ratio which we talk. Coming to next question, which of the following amino acid is primarily responsible for buffering in blood due to its ability to accept and donate the proton at physiological pH? So, what is the physiological pH? It is 7.35 to 7.45, and the amino acid which is having the nearest dissociation constant is the histidine. Histidine is the amino acid jiska dissociation constant is going to be 6.8, which is nearest to physiological pH. So, this histidine is going to act as a best buffer amino acid, right, best buffering amino acid. Now, coming to the next question, a patient with a history of strenuous exercise, means heavily exercising, patient is a lot of exercise, is skipping a meal and later consuming alcohol at a party. Okay. Exercise, low glucose, skipping meal, low glucose, then consuming alcohol, then alcohol is inhibiting which of the biochemical process resulting in hypoglycemia. It is very common to see that alcoholic patient is coming in a comatose state due to hypoglycemia. So, please understand a chronic alcoholic is very prone for hypoglycemia, and the reason is this person will have problem in the making of glucose, that is gluconeogenesis. So, I will explain you this how like this problem is occurring in chronic alcoholics, why the gluconeogenesis process is not handling the hypoglycemic state and patient is lapsing in frank hypoglycemic coma. I explain you. Now, when you talk about alcohol, when a person is consuming alcohol for a long time, the metabolism of alcohol takes place in the liver. You have the conversion of alcohol to acetaldehyde during metabolism, and this acetaldehyde is converted to acetate during its metabolism. Okay. Now, the enzyme is alcohol dehydrogenase at this point and acetaldehyde dehydrogenase at this point. And the interesting fact is that both these two enzymes require NAD as their coenzyme. So, what is happening? The NADH is secreted during this reaction. NADH is secreted during is like produced during this metabolism of alcohol. So, in a chronic alcoholic patient, NADH level in the liver is going to be very high. Now, this is the crux of all the problems. This increased NADH will start doing all nonsense in the hepatic cell. It will start converting pyruvate to lactate, because pyruvate to lactate conversion require NADH. It will start converting oxaloacetate to malate, because conversion of oxaloacetate to malate require NADH. Now, please understand that this pyruvate and this pyruvate and this you know, the oxaloacetate, they are important gluconeogenic substances, substrates for gluconeogenesis. So, when they are converted to lactate or malate respectively, the person will not get the material for gluconeogenesis. So, if anybody asks you why chronic alcoholic is not able to synthesize glucose, you blame it to alcohol metabolism, which is going to raise the level of NADH in the liver, and this increased NADH in the liver is doing all nonsense, converting the pyruvate to lactate. So, pyruvate is not available for gluconeogenesis, converting oxaloacetate to malate. So, level of oxaloacetate is also low. So, that cell is not sensing the process of gluconeogenesis. So, that is the problem. And the increased NADH is also responsible for the fact that chronic alcoholic patient after a alcohol binge gets lactic acidosis, because pyruvate is converted to lactate, and because of this lactic acid, uric acid is not excreted, resulting in hyperuricemia. Uric acid is going to be high, patient will present with gouty manifestation, because lactic acid impairs the uric acid excretion. So, you just imagine a person who is a chronic alcoholic suddenly going to a party and having, you know, a lot of alcohol there, and next day morning coming to you and telling, docs, of this and all has happened, my I am getting pain in the great toe, I am, you know, having restlessness, my lactic acid is high, you see, and I am getting hypoglycemia, you know. So, those things are all connected here, because high NADH is resulting in so many problems. High NADH means lactic acidosis, high NADH means no gluconeogenesis, and lactic acidosis means hyperuricemia, right. So, this is how it is, problem of alcohol intake. And vision issue, yes, vision issue, if there was a question, Archita, please remember that vision issue will come in alcohol intake only if the alcohol is methyl alcohol, not the ethyl alcohol. In ethyl alcohol intake, which is the common alcohol available in the market, ethyl alcohol, vision problem will not be there, because ethyl alcohol only is metabolized like this, which I have told you. The vision problem will come only in the methyl alcohol intake, which you call it as a contaminated spirit. When that is undergoing metabolism, it is going to result in formation of formaldehyde, bacha, formaldehyde. And this formaldehyde is dangerous. It is a gas, volatile gas, it enters the retina and spoils it, retinopathy. So, that every time you hear in the news, right, that contaminated spirit or poisonous alcohol consumption resulting in blindness, you know, in this community. So, that is a methyl alcohol intake. If the ethyl alcohol is not available, and if chronic alcoholic is getting methyl alcohol, he will drink, and that will result in a problem, and that will result in a blindness. So, to counter this, what happens if the patient is timely reporting to the emergency unit, and if doctor knows that person has consumed methyl alcohol, the doctor will give the ethyl alcohol, lo baba, drink ethyl alcohol. Why? Because the alcohol dehydrogenase will not act on methyl alcohol, then it will start acting on the ethyl alcohol, and the production of formaldehyde will be reduced, and the chances of getting blindness will be much reduced. So, this you must know, and this is often very much asked to you, and this is mostly asked to you in you know, the frame a question that what type of inhibition is like acting here. You say it is a competitive inhibition, because alcohol dehydrogenase is the common enzyme for ethyl alcohol as well as for the methyl alcohol, and when methyl alcohol is there and suddenly you bring the ethyl alcohol, alcohol dehydrogenase will go to the ethyl alcohol, sparing the methyl alcohol. So, it is example of, typical example of competitive inhibition of enzyme, which you will be learning in regular classes in detail, right. All right. Now coming to the next question, which of the following enzyme is dependent on vitamin C for its activity? I think it's a repeat recall and I have already discussed in detail. It is prolyl hydroxylase and lysyl hydroxylase. So, answer in this question is going to be this. Coming to the next question, child presenting with micrognathia. Micrognathia means a small mouth, low set ears. These clinical features are commonly associated with which type of genetic abnormality? You remember it is deletion. In fact, this is a part of a big question which they asked regarding Prader-Willi syndrome. I will discuss you that further. That question is going to come somewhere. Wait. So, Prader-Willi syndrome is actually the paternal chromosome deletion, where chromosome number 15 is showing the deletion, and that will result in Prader-Willi syndrome with a small mouth and low lips and thin lips, upper lips, and you know, the upward upper canthus of the eye, flat nasal bridge, short stature, more of eating, so obesity. All these problems will be there in the Prader-Willi syndrome, which is due to deletion at certain bands of chromosome 15. It is Q11 and Q13 bands. Now coming to next question, hypertensive patient, hypernatremia, more of the sodium, hypokalemia, less of the potassium, and metabolic alkalosis. It is a very typical presentation of primary aldosteronism, that is Conn's syndrome, with the hypertension, hypernatremia, hypokalemia, metabolic alkalosis. It is a very typical presentation of Conn's syndrome, which is primary aldosteronism. More of the aldosterone is secreted due to tumors in the adrenal gland. Right. Coming to next question, and this is a picture which is showing you various important aspects of Conn's syndrome. There is adrenal tumor, so more of the aldosterone is secreted. That will result in more of the BP, less of the potassium, you know, the polyuria and the fatigue. Now coming to this child who is having bow leg, normal calcium, high PTH, typical presentation of rickets. Right. So, answer is rickets. Can you see the bowing of the leg? Even in X-ray, very typically you can see the bowing of the leg. So, in rickets, due to vitamin D deficiency, there is initially low of the calcium, which will stimulate the PTH secretion, parathyroid hormone, and this parathyroid hormone will start reabsorbing the calcium, making the calcium normal. So, most of the cases of rickets, the calcium is going to be normal, and this increased PTH will lead to phosphaturia, that is the phosphate will be excreted through urine. So, low of the phosphate. So, the typical presentation in rickets will be low or normal calcium, low phosphate for sure, high PTH level, low vitamin D level, right. Any doubt here? Very good. Okay. Now coming to next question, 8-year-old child presenting with obesity, developmental delay, paternal deletion, father chromosome deletion, obesity, developmental delay, chromosome in, this is only Prader-Willi syndrome, which I was discussing you. It is chromosome number 15, chromosome number 15. Now 45-year-old chronic alcoholic, tremors, anxiety, hallucination, last drinking alcohol 48 hours back. Now what is the diagnosis? Delirium tremens. You remember, this is a very typical presentation of delirium tremens, where immediately the manifestation will not be there. After 2 days of drinking alcohol, the patient will be presenting with anxiety, tremors and hallucination, right. What is the primary mechanism of tissue damage in long standing diabetes? You must know in diabetes there is uncontrolled sugar in the blood. Sugar means glucose, high glucose, hyperglycemia, and that excessive glucose will start destroying all the proteins, you know, that will result in formation of advanced glycation end products, which will make havoc in the system, will result in complications of diabetes. So, the main reason of various complications of the diabetes and the tissue damages is the more of the glucose, advanced glycation end products, right. So, the answer is going to be hyperglycemia, hyperglycemia. glycemia is the culprit. So, if you are able to control the blood glucose in a diabetic patient to acceptable limit, the diabetic patient will not have any complication even in the long term. The patient will be happy and healthy, right. So, it is very important to take your blood glucose in a patient who is diabetic. Now, 4-day-old neonate is presenting with 15 milligram per deciliter of bilirubin. They have not mentioned what type of bilirubin, whether it is direct or indirect. So, we consider this as a total bilirubin. Now, the most probable causes. Now, this is a patient, baby coming with the jaundice. Now, what is important? The level of bilirubin is important in this to understand the disease, and the duration at what time the baby is presenting with the high bilirubin is again significant. Now, it is not at the time of birth, right. At the time of birth means it is some pathological type of jaundice, maybe Dubin-Johnson syndrome or the Rotor syndrome, some hereditary problem if involved will result in occurrence of jaundice, or in that case Rh incompatibility will result in immediate jaundice soon after birth. But this baby was healthy for 3 days and suddenly at 4th day developing the jaundice with bilirubin not very high, not exceeding 15 milligram per deciliter, not going to the range of 20-25 milligram per deciliter. So, it looks like a physiological jaundice, right, which appears little late, and its level of bilirubin is also going to be within 15 milligram per deciliter. So, it is a case of physiological jaundice. When we talk about Gilbert syndrome, at the time of the birth itself baby will have jaundice, and it is autosomal dominant disorder, and that the problem is in the conjugation of the bilirubin. So, a lot of unconjugated bilirubin will be there in the system, in the blood. Hemolysis also, the baby will have the jaundice immediately after birth, Rh incompatibility cases, you find the baby jaundiced at the time of birth, and there again you have most of the bilirubin being unconjugated. And Crigler-Najjar syndrome is similar to Gilbert syndrome, but it is autosomal recessive disorder, and there again the conjugation of bilirubin is defective, resulting in unconjugated bilirubinemia. So, in this the answer is very simple, and answer is going to be physiological jaundice, for simple reason that it is not occurring at the time of birth. After 2-3 days the jaundice is appearing, and the level of bilirubin is going to be sort of 15 milligram per deciliter. All other options will have unconjugated bilirubin, which will be very high and which is going to show its face at the time of birth itself, right. All right, Archita, no question from your end. Rahul, Archita, Mohammed, please ask me if anything is coming in your mind or any recall of the option. All right, now coming to the next question. Patient presenting with vomiting, arterial blood gas analysis is revealing pH 7.5. So, pH is high. Partial pressure of carbon dioxide is 48 millimeter mercury, low or high? It is again high, because partial pressure of carbon dioxide normal level is 35 to 45 millimeter of mercury. Bicarbonate is again 22 to 26 is the normal, it is 30, it is again high, everything is high. So, pH if it is high, it is alkalosis number 1. First catch pH, it is alkalosis. Now, whether it is metabolic alkalosis or respiratory alkalosis, it cannot be respiratory alkalosis, because respiration has got something to do with the carbon dioxide, and if partial pressure carbon dioxide is high, it will be acidosis, not alkalosis. So, it will not be a respiratory alkalosis. When we talk about bicarbonate level here, this is also high, and high bicarbonate is the metabolic cause. So, this is a case of metabolic alkalosis. So, this kind of question looks tough, but it is very easy to solve. I again explain you, when this kind of parameters are being given to you, first of all you locate the pH, whether it is high or low. Normal is 7.35 to 7.45, so it is certainly high. High means it is alkalosis. If it is low, it is acidosis. So, first you write it is alkalosis. Now, the question is respiratory or metabolic. If it is respiratory alkalosis, the PCO2 will be low, but in this it is high. So, it cannot be respiratory alkalosis. So, bicarbonate level normal is 35 to normal is 22 to 26 millimeter mercury, it is high. So, certainly it is a case of metabolic alkalosis, right. So, this is how you have to attempt such questions. You can have low pH, right. you can have low pH, PCO2 may be high given in that option, and bicarbonate also low. So, low pH means it is acidosis, bicarbonate low means it is not the metabolic acidosis, and PCO2 high means it is a respiratory acidosis, right. So, this is how you have to come to calculation. Okay, again alcoholic patient hypoglycemia, it is the same recall. What is the most likely cause of hypoglycemia? I said gluconeogenesis will be impaired. So, answer is decreased gluconeogenesis. I have discussed this question already in big detail. So, thank you very much and wish you all the best. Thank you.